Although far less common than dilated cardiomyopathy, hypertrophic cardiomyopathy is nevertheless a unique disease entity with a fascinating morphologic and pathophysiologic spectrum. Echocardiography has contributed immensely to our understanding of the pathophysiology of this disease entity. The primary pathologic feature is hypertrophy of the ventricles, which occurs without an obvious underlying cause, such as hypertension or valvular aortic stenosis. The hypertrophy is often disproportionate rather than concentric. Most commonly, the ventricular septum is hypertrophied to a greater degree than the posterior wall, referred to as asymmetric septal hypertrophy, or ASH. The ventricular chambers are usually small in hypertrophic cardiomyopathy. A dynamic systolic gradient is a common but not invariable finding. Several different morphologic variants of hypertrophic cardiomyopathy are recognized. Two-dimensional echocardiography has provided us with delineation of the full morphologic spectrum, and 2D echo is also excellent for characterizing systolic function. As with other entities, M-mode is useful for measuring chamber and wall dimensions. Furthermore, M-mode provided some of the earliest insights into the pathophysiology of hypertrophic cardiomyopathy, with demonstration of dynamic obstruction of the LV outflow tract due to systolic anterior motion, abbreviated as SAM, of the mitral valve. The resultant mid-systolic closure of the aortic valve can also be documented with M-mode. In recent years, Doppler echocardiography has permitted non-invasive hemodynamic assessment of the obstructive form, as well as providing a means of characterizing diastolic dysfunction. Flow imaging provides an angiographic-like display which is particularly useful for semi-quantitation of the mitral regurgitation that is almost always present with the obstructive form. Color Doppler is also used to enhance our understanding of the filling profiles associated with the several morphologic variants. We will first display the use of 2D and M-mode in hypertrophic cardiomyopathy, and we will then demonstrate the utility of Doppler and flow imaging in this entity. This parasternal long-axis view from a 32-year-old male demonstrates the most common morphologic variant of hypertrophic cardiomyopathy, with increased thickness of the entire ventricular septum. Note the normal thickness of the posterior wall. Ejection of blood into the outflow tract, bordered by the hypertrophied septum, creates a Venturi effect that sucks the free edge of the mitral leaflets against the septum. This is SAM, which is responsible for the dynamic left ventricular outflow tract gradient. This 14-year-old male has an extreme form of hypertrophic cardiomyopathy, and each member of his family had this same appearance. There is tremendous hypertrophy of the ventricular septum compared to only mild hypertrophy of the posterior wall. Note the abnormal texture of the septal myocardium, consisting of a highly refractile, granular appearance, which is typical for hypertrophic cardiomyopathy. The left ventricular cavity is small, such that the anterior mitral leaflet abuts the septum in diastole. In systole, systolic anterior motion of the mitral leaflets obstructs the left ventricular outflow tract. In real time, pay attention to both the SAM and to the hyperdynamic function with nearly complete cavity obliteration in systole. In parasternal short-axis format, the abnormal texture is again apparent. The papillary muscles are mildly hypertrophied. Marked hypertrophy extends from the septum to the anterior wall. The lateral wall is involved to a lesser extent. Curiously, the inferior wall is the least commonly involved in this disease. Midventricular cavity obliteration is evident. This is a parasternal long axis image from a 56-year-old male with hypertrophic cardiomyopathy. An M-mode cursor crosses the left ventricle. In addition to the cavity dimensions for systolic function calculations, you can appreciate how M-mode allows precise measurement of the thickness of the septum and posterior wall. The cursor now crosses the tips of the mitral leaflets. This is the typical appearance of systolic anterior motion by M-mode. In this case, the obstruction is not as severe as those previously displayed. The mitral leaflets do not fully obliterate the outflow tract in systole. We will now display the spectrum of morphologic presentations of hypertrophic cardiomyopathy. This is the most typical appearance. The asymmetric septal hypertrophy in this patient involves the base to a lesser extent than the mid and apical levels. Note the apical cavity obliteration. In apical long axis format, systolic anterior mitral motion is clearly seen to obstruct the LVOT. This is a similar case in apex down orientation. The marked septal hypertrophy is more prominent at the mid-level than at either base or apex. This gives the septum a lemon-shaped appearance. The lateral wall is involved to a lesser extent. The left atrium is moderately enlarged. Now the regional expansion function of the instrument is being used to focus on the SAM. This is a variant with more concentric hypertrophy. Note that the involvement of the lateral wall is as extensive as the septal involvement. In this parasternal long axis view, you will notice the relatively localized bulge in the basal septum. This appearance is most common in elderly patients and is largely due to the sigmoid shape of the senile septum on cross-section. In this case, the basal septal hypertrophy is associated with outflow tract obstruction, as evidenced by the systolic anterior motion. Apical hypertrophic cardiomyopathy is an unusual form, first described by Japanese investigators. These patients have a typical ECG pattern, illustrated here by a tracing from a 64-year-old male. Note the deep T-wave inversions in the precordial leads. On 2D examination, hypertrophy either exclusively or predominantly involves the apex. It is important to properly adjust the gain settings to delineate this abnormality. The hypertrophy creates a narrow apical cavity, which gives the left ventricle this characteristic ace of spades appearance. Having described 2D findings for the various morphologic forms of hypertrophic cardiomyopathy, we will next turn our attention to the use of Doppler in this disease entity. For patients with the obstructive variety of hypertrophic cardiomyopathy, the site of intraventricular obstruction is verified by pulse Doppler or color flow imaging, and the severity is determined by continuous wave Doppler. Not only is the gradient measured in the resting state, but also the Doppler exam can be used to determine the response of the gradient to various maneuvers and drugs. Mitral regurgitation is commonly found in patients with hypertrophic cardiomyopathy. We use flow imaging to semi-quantitate the severity. Doppler echocardiography is also used to analyze diastolic function in patients with hypertrophic cardiomyopathy. This is an apex-down, long-axis view from a 62-year-old female with hypertrophic cardiomyopathy. Note the septal hypertrophy and the systolic anterior motion of the mitral valve. She has mild obstruction in the resting state. The mitral valve does not completely abut the septum. The left atrium is moderately enlarged. Pulsed wave scanning will be used to verify the site of obstruction. For this examination, the small 2D image is displayed with apex up orientation. We begin with the sample volume at the apex. The systolic velocity is 0.4 meters per second. Now the proximal portion of the sample volume has reached the level of the systolic anterior motion. The systolic velocity increases to 1.2 meters per second. Finally, the entire sample volume has been moved to a level just beyond the SAM. The systolic velocity has accelerated to 1.6 meters per second. We will now demonstrate this pulsed wave scan in real time, and you will both see and hear the velocity increase as the sample volume reaches the site of obstruction. This 16-year-old male has severe hypertrophic cardiomyopathy. Systolic anterior motion completely obstructs the LVOT in this frame. Color flow imaging quickly verifies the level of obstruction, which is identified as the site where color aliasing begins. The severity of left ventricular outflow tract obstruction is determined with continuous wave Doppler. Signals are usually delineated best from an apical transducer location, although occasionally other locations, such as left peristernal, also yield a clearly defined envelope. Since, from an apical transducer position, the velocity of intraventricular obstruction, as well as mitral regurgitation, are directed away from the transducer, and are systolic in timing, occasionally these can be mistaken for each other. Therefore, some attention to detail is necessary to avoid confusion. Dynamic left ventricular outflow tract obstruction has a characteristic appearance. The peak is delayed, such that the CW spectrum is dagger-shaped. In this case, the maximum velocity is 4.2 meters per second. Using the Bernoulli equation, this calculates to a maximum instantaneous gradient of about 70 millimeters of mercury. Note this gap from the end of the ejection to the onset of mitral flow, which is the isovolumic relaxation period. By identifying this, we can be certain that this velocity spectrum is occurring during the ejection period and is therefore the velocity of obstruction. This CW recording is also from a patient with hypertrophic cardiomyopathy using an apical transducer location. The peak systolic velocity is 7 meters per second. However, this is not the spectrum representing obstruction. Note that there are no gaps at the isovolumic periods. This spectrum is holosystolic and therefore must represent mitral regurgitation. Identification of the isovolumic periods is critical in correctly identifying the spectrum representing obstruction for gradient calculation. Hypertrophic cardiomyopathy is characterized by a gradient that is dynamic. This dynamic feature can be nicely demonstrated in the non-invasive laboratory using continuous wave Doppler. This sequence illustrates how the gradient can be manipulated. In the resting state, the peak velocity is 2.1 meters per second, which calculates to a gradient of 18 millimeters of mercury. Next, the patient performs a Valsalva maneuver, and the velocity increases to 4.5 meters per second, which is a gradient of 81 millimeters of mercury. Finally, we have the patient inhale amyl nitrite, and the gradient increases to 121 millimeters of mercury. This patient with hypertrophic cardiomyopathy has a spectrum representing obstruction with a peak at 3 meters per second in the resting state. The calibrations here are 0.5 meters per second. With Valsalva, the spectrum briefly disappears and then reappears with an increased velocity of 5.5 meters per second, which is a peak gradient of 121 millimeters of mercury. We will now play the entire sequence in real time. Dr. Sasson and the group at Stanford have studied hundreds of cardiac cycles from 5 patients with hypertrophic cardiomyopathy who underwent catheterization simultaneously with Doppler measurement of the LVOT velocity. Their results show an excellent correlation between the non-invasive Doppler gradient and the invasively determined gradient with an R value of 0.96 and a standard error of the estimate of 3.9 millimeters of mercury. For patients with a high degree of obstruction in the basal state, or for patients whose symptoms persist despite medical therapy, we recommend partial septal myotomy-myectomy. This surgical procedure relieves outflow obstruction and provides excellent relief of symptoms. Postoperatively, Doppler evaluation allows us to non-invasively assess the degree to which the obstruction has been reduced. This CW spectrum is from a 29-year-old male who is 7 years post-myotomy-myectomy. Prior to surgery, we measured a 94 millimeter outflow tract gradient. Now, postoperatively, his LVOT velocity is 1.2 meters per second, which is normal. Both the isovolumic contraction and isovolumic relaxation periods are evident. Color flow imaging can be used to semi-quantitate the degree of mitral regurgitation in hypertrophic cardiomyopathy. In this case, the 2D exam clearly demonstrates LVOT obstruction. The sector has been narrowed to enhance flow imaging. The mosaic signals in the outflow tract are due to the high degree of obstruction. Mild mitral regurgitation is evident. The jet is directed posterolaterally. This is a parasternal long-axis view from a 5-year-old child with hypertrophic cardiomyopathy. Once again, the mosaic pattern in the LVOT identifies obstruction. A broad jet of mitral regurgitation tracks along the atrial surface of the posterior mitral leaflet. The regurgitation is moderate in severity. The semi-quantitation of mitral regurgitation can be made both in the baseline state and following maneuvers or drugs. This latter is particularly useful for patients being considered for septal myotomy-myectomy. It is important to determine whether their mitral regurgitation greatly diminishes with manipulations that reduce the outflow obstruction. If so, the regurgitation is due to obstruction and therefore is expected to be diminished or completely abolished with surgical relief of obstruction. This apical long-axis view demonstrates left ventricular outflow tract obstruction. The gradient was 100 millimeters of mercury by CW Doppler exam. The obstruction is identified by the mosaic pattern in the LVOT. A jet of severe mitral regurgitation fills the left atrium. In most cases of hypertrophic cardiomyopathy, mitral regurgitation is a consequence of systolic anterior motion. Initial rapid ejection results in a Venturi effect, which sucks the mitral apparatus toward the septum. This systolic anterior motion leads to abnormal mitral coaptation, with resultant mitral regurgitation. This sequence, eject, obstruct, leak, was initially proposed by Dr. Weigel at the University of Toronto, based on analysis of left ventriculograms. This sequence of events was verified by Dr. Nishimura using color flow imaging. In this diastolic frame, mitral inflow is encoded in red. Now, in early systole, a laminar pattern of ejection is noted. There is uniform blue with color aliasing. The ECG cursor indicates that we are at mid-systole. Obstruction is denoted by the mosaic pattern in the LVOT. Now the ECG cursor is at the T wave. In late systole, a jet of MR is clearly defined. Color M mode can also be used for precise timing of these systolic events in hypertrophic obstructive cardiomyopathy. The 2D image is in parasternal short axis orientation. The M mode cursor crosses the LVOT and the left atrium. This is the resultant color M mode: mitral valve, LVOT, and left atrium. In early systole, the uniform blue indicates laminar ejection, which is followed by the mosaic pattern of obstruction, which is followed by the mosaic pattern of mitral regurgitation in the left atrium. Of course, we know from CW analysis that the mitral regurgitation is actually holosystolic, even though the greatest volume of regurgitation occurs in mid to late systole. As our instruments have become more sensitive, we are able to detect the weaker early signals of MR, as well as the strong signals of the fully developed jet later in systole. In this case, we have captured a cardiac cycle on the instrument's cine loop. We can then use the trackball to select frames at points throughout the cardiac cycle. Here, we are in early systole, and the red signals are typical for laminar ejection. Note the faint jet of mitral regurgitation. With obstruction, indicated by the mosaic pattern, the MR signals become more prominent. A small mosaic jet is seen in the left atrium. We have now moved to late systole. The turbulent jet of mitral regurgitation is fully developed. Up to this point, we have been discussing systolic aberrations of hypertrophic cardiomyopathy, but this is also a disease of diastole. The massive hypertrophy leads to marked diastolic dysfunction. As with dilated cardiomyopathy, we currently recognize two types of abnormal diastolic patterns. This is the most common, the pattern of abnormal relaxation. The E velocity is reduced, and the A velocity is increased, such that the E to A ratio is much less than 1. The deceleration time is prolonged. Not displayed here is the isovolumic relaxation time, which was also prolonged. In contrast, this patient with hypertrophic cardiomyopathy has a restrictive pattern of left ventricular inflow. The sample volume is at the tip of the mitral leaflets. The E to A ratio is increased, and the deceleration time is 160 milliseconds. As previously mentioned, this restrictive pattern is usually found in patients who are the most symptomatic. When characterizing diastolic function of the left ventricle, we also sample left atrial inflow from the pulmonary veins. This spectrum was obtained from the right paraseptal pulmonary vein of a patient with hypertrophic cardiomyopathy. The systolic and diastolic velocities appear normal. However, note that there is a very prominent flow reversal of 0.4 meters per second in the pulmonary vein following atrial systole. This is indicative of abnormal diastolic filling. Sampling pulmonary venous flow is particularly useful in cases of suspected diastolic dysfunction when the mitral flow profile appears normal. This spectrum was obtained from a patient with hypertrophic cardiomyopathy using a CW transducer at the apex. It illustrates a typical feature of this disorder first described by Dr. Hatley. This is the E velocity, which is reduced. The A velocity is accentuated. Hence, the pattern is that of abnormal relaxation. This large velocity spike of 2 meters per second occurs between the end of ejection and the onset of mitral flow. That is, it occurs during the isovolumic relaxation time. With hypertrophic cardiomyopathy, the apex relaxes before the base. This results in displacement of the end systolic volume of blood toward the apex. It is the velocity of this displacement which we record by Doppler during isovolumic relaxation. This IVRT signal, therefore, is a manifestation of dysynchronous relaxation. You must be careful not to mistake this signal for the E velocity. Hypertrophic cardiomyopathy is a unique disease entity. 2D and Doppler with flow imaging provide a comprehensive, non-invasive assessment of patients with this disorder, allowing complete definition of morphology, ventricular function, and abnormal hemodynamics, both systolic and diastolic. When assessing patients with hypertrophic cardiomyopathy, catheterization is rarely indicated. When invasive study is required, It is usually to define coronary anatomy. This parasternal long axis view from a 10-year-old female shows concentric left ventricular hypertrophy. There is systolic anterior motion of the mitral apparatus. Her diagnosis was evident on clinical exam. She has Friedreich's ataxia. This is a specific disorder affecting cardiac muscle, which has a morphologic appearance very similar to hypertrophic cardiomyopathy. Using 2D and Doppler echo, both systolic and diastolic function can be followed serially in this disorder.